Hello and welcome. Today we're doing a rapid review of deep vein thrombosis, or DVT, focusing on the essential high-yield points. Let's get straight to it. Pathophysiology. The foundation of DVT is Virchow's triad: venous stasis, hypercoagulability, and endothelial injury. Classification. The key distinction is anatomical. Proximal DVT involves the popliteal, femoral, or iliac veins and carries a high risk of causing a pulmonary embolism. Distal DVT is confined to the calf vein. Risk factors. Think in terms of strength. Major risk factors include major surgery, especially orthopedic, hospitalization, active cancer, and a prior VTE. A crucial concept is the unprovoked DVT, where no clear cause is found, which has implications for long-term treatment. Symptoms. The classic presentation includes unilateral leg swelling, pain, often like a cramp, warmth, and redness. The diagnostic algorithm. This is a critical pathway to master. Assess clinical probability. Start with the Wells score. Follow the score. If the Wells score is 1 or less, DVT unlikely, perform a D-dimer test. If the D-dimer is negative, DVT is ruled out. If it's positive, you must proceed to an ultrasound. If the Wells score is 2 or more, DVT likely, skip the D-dimer and go directly to a whole leg compression ultrasound. Modern treatment principles. Treatment is stratified into initial, long-term, and extended phases. First-line therapy. For most patients, the recommendation is to start a direct oral anticoagulant, DOAC, such as apixaban or rivaroxaban, immediately. The old approach of bridging with heparin to warfarin is no longer the standard of care for the majority of cases. Key exceptions. In patients with cancer or who are pregnant, injectable low molecular weight heparin, LMWH, is the preferred agent. For patients with severe renal failure or hemodynamic instability, unfractionated heparin is used. Duration of treatment. For a DVT with a clear, temporary cause, a provoked DVT, the standard duration is 3 months. For an unprovoked DVT, extended anticoagulation beyond 3 months is often recommended after weighing the risks of recurrence versus bleeding. Advanced therapies, the exceptions, not the rule. Catheter-directed thrombolysis is reserved for severe, limb-threatening DVT in patients with a low bleeding risk. Inferior vena cava (IVC) filters are indicated primarily for patients with an acute DVT who have an absolute contraindication to all forms of anticoagulation. Summary. To recap the most vital points, use the Wells score to guide your diagnostic pathway. For most patients, treat with a DOAC first. And remember that advanced therapies are for highly specific and severe situations. That's your high-yield summary of DVT management. Thanks for watching, and be sure to subscribe for more clinical reviews.